Thanks for joining us on Not Boring CEs, where we don't think you should be bored to death while getting your continuing ed. Keep listening here, then hop over to notboringces.com to get all your online CE credits. All right, y'all, let's get to learning. Emily Foxencraft, PhD, is a pediatric pain psychologist with over 7 years of experience and the enthusiastic owner of Pediatric Pain and Behavioral Health. She provides treatment to children, teens, and young adults with chronic pain, chronic illness, and anxiety. Common concerns include headaches, digestive symptoms, sports injuries, and stress, but she always personalizes care to help the individual and family learn to manage their symptoms, improve functioning, and develop resilience for life. Dr. Foxencraft is a licensed psychologist in the state of Michigan, but is also authorized to provide interjurisdictional telehealth to 40 states through SIPACT. Prior to launching Pediatric Pain and Behavioral Health, she helped found the University of Michigan's Pediatric Chronic Pain Program as a postdoctoral fellow, and then as a faculty member in the departments of pediatrics and anesthesiology. She continues to conduct and publish research and to educate psychology trainees as well as pediatricians and pediatric pain management. Welcome, Emily. Welcome back to Not Boring CEs. I'm here with Emily Foxencraft, and today we are talking about pain psychology across the lifespan. If you haven't caught any of Emily's other CEs with us, definitely check those out. And today we're just talking about how, it's not something that just happens in older age or middle age or childhood. Like, we experience pain as a group of people the whole way through this journey. So I'm excited to talk to you about it and learn some more. So where should we start? Should we go chronologically?
Sure. Yeah. Well, thank you for having me. And thanks to anybody who's listening in and taking an interest in this subject. And I think it is interesting to think about, first of all, what is similar? What are some universal principles? And I think that word universal is just a great place to start. Like you were saying, pain is a pretty ubiquitous universal experience, with the rare exception of some individuals who maybe have some very, very rare genetic abnormalities. We all experience pain, and scientists and researchers debate exactly when that transition starts, but it is in the prenatal period. That's pretty universally accepted, and well, certainly early or from early on in birth to throughout our development, throughout our lives, we all do experience pain. We experience pain acutely, and we all have the capability of experiencing chronic forms of pain. And so that universality, I think, is just an important principle to start with, and to think about, the whole lifespan. Adults in pain often report that their pain started in childhood. So again, considering an individual and their whole lives. Also considering that all pain that we all experience, whether it's acute or chronic, is biopsychosocial in nature. That's part of the definition of pain. Pain, whether it's acute or chronic, has biological components, psychological components, social components. That's really hard to disentangle what's what, because they all relate and are dynamic. All pain hinges on communication. It hinges on communication between the brain and the body for the pain experience. And it hinges on our ability to communicate and express that to others, and for others to and to appreciate how the unique individual communicates. As people, regardless of age, because I think we often focus on early childhood being a core part of development, but we're all developing throughout our lives. There's constant change of growth and decline constantly throughout our lifespan. And then sometimes thinking about less about age and more about the individual and their comorbidities. So there's some literature that really suggests that what actually makes a bigger difference in predicting pain and pain-related outcomes is less about the age of the individual and more about what they have going on in their lives. Is there the degree of psychological distress, the degree of sleep impairments, other health conditions might impact somebody a lot more than exactly their chronological age. So I really liked this axiom of focusing on the individual in pain, not the pain in the individual. I did not write that, but I think it's really well worth remembering. But then we can start to think about the differences and what might be unique about each stage. And I think before we get into the word stage, really taking a moment and taking a pause and recognizing that age is and age and development is along a continuum. Although I specialize in pediatrics, we are constantly redefining what the age of pediatrics really is. And when you think about that age range, whether you can cut it off strictly at 18 or maybe more a developmental stage that might end in, maybe in young adulthood or early 20s, that is a large age range and a large developmental, psychological, social, biological change. Can you think about a 17, 11-month-year-old and what they have in common with an infant? There's a big range there. And even in adult care, there might be a lot of differences biologically, psychologically, socially between a 21-year-old and a almost 60-year-old. So again, a lot of differences, and especially that cutoff for geriatrics kind of can seem artificial when you compare 65-year-old, one month old to a 64-year-old, 11-month-old. Not a lot of changes that you might think about there. So I think, the field is moving more to considering the lifespan. And I've been really excited as a pediatric specialist to be able to partner with clinicians and researchers who do work more with different populations to be able to think about, people along a continuum and along the course of the trajectory of their lives.
Oh, I have so many questions. Maybe we'll get into it more because you'll probably answer a lot of them as we go. But I'm just thinking about differences within and differences without, like just how the experience of pain or illness across the lifespan is probably very similar in many ways, but also very different. So I'm just thinking about those dynamics. I'm also thinking about identity, like identifying as someone with a disability, for instance, or identifying there's a real beauty and acceptance with that in many cases, and to find community and to ask for what you need. And then there's also difficulty for some people in over-identifying with diagnoses or struggles that they have. So I'm also very interested in what that looks like across the lifespan. If there are peak times for that versus not. So basically, just talk, tell me everything.
Very much. I think, yeah, you're right. No matter the age, it's this constant interplay between accepting and appreciate what's going on with your life, but also looking forward to change and growth and continued development. And that's a constant interplay, but you can imagine the duration that somebody may have been experiencing their pain or their illness might factor in. So I get the privilege of working with kids. And I think one of the fun things about working with kids is that there is this appreciation for change and growth and resilience. And, I can kind of accept the way my life is right now. Maybe it's a little easier because, even if a teenager they report they've been experiencing pain for many years, it is maybe and it's a large portion of their lives. Maybe it is a little less in duration than an adult who may have been experiencing something for decades. And then there's this, this willingness to try new things and grow, whereas somebody who maybe has experienced something for decades or has formed an identity around somebody with an illness or condition, maybe in some ways a little bit more resistant or hesitant about change for various understandable reasons. So I think that is this constant interplay. But some of these concepts of acceptance and commitment are a little abstract, but I think, and so, the tendency in the past has been to save ACT basically, or ACT-based treatments for later teens or adulthood. But I think there is some really exciting work being done to adapt it to the mindset and reality of younger children, and just recognize that maybe it looks a little different, or our language looks a little different. But we can use those experiential learning techniques and those concepts in younger children to help them grow and develop. So I'm appreciative of the people putting a lot of stock and work into that. Yeah, but when we think about kids, we start to think about these differences and changes that occur in the lifespan. Let's think about what childhood and pediatric development often involves, and then we can start to think about, well, how might that affect pain, or how that affect pain expression, pain experience, and pain related disability. So early childhood thinking little kids, infants, toddlers, preschool age, all the way through early elementary, is really marked by, as we know, rapid brain growth, rapid learning, growing abilities to communicate and express and regulate behavior. And you can imagine all of those start to play in to how somebody experiences, expresses, and manages pain. And so all of those factors have to be taken into account when you're starting to assess and treat. We, as people, we typically start to develop our ability to inhibit pain signals. So our brain to send signals back down to our body to reduce pain signals starts at about 1 month old.
Oh,
So
wow.
that's yeah. So, I mean, we have a month where, I think we need to protect our little babies. But we start to develop these self-regulation processes 1 month into life, which I think is just remarkable. And those continue to develop and grow. Whereas we kind of start to think about middle childhood, early adolescence. This is when our nervous system is beginning to mature a little bit more. It looks quite different than earlier childhood. There's obviously starts to become prepubertal and pubertal factors. And then complex social change that I think is just, for those of us who are a step removed from that, we're starting to appreciate how rapidly things really seem to be changing for the younger generations. And so because of some of these changes, we do see some differences in how pain is experienced or diagnosed. So some conditions seem to be more prominent in pediatric populations, and the chronic pain conditions tend to onset a little bit more in that middle childhood or early adolescence or in adolescent years. So some of those factors that I just described really seem to factor in, although I think the challenges with communicating pain are maybe part of what challenges clinicians and parents in working with younger children and appreciating that these things might be going on. But it is more rare because of some of the development of the nervous system that's still happening. But so in middle childhood, adolescence, we start to see more common chronic pain presentations. And the most common ones that typically are reported are headache and migraine conditions, abdominal pain conditions, and widespread musculoskeletal pain conditions. So primary pain conditions that are occurring in different parts of the body. So one thing that we start to see is, CRPS, or complex regional pain syndrome, which is widely thought to be a neuropathic pain condition having to do with nervous system dysregulation and or damage. And that can only happen is when the nervous system reaches a certain stage of development. So we typically only see that beginning around 8 to 10 years old on average. And migraine conditions may also look a little different in pediatrics. So we commonly think of headaches and migraines, or migraines specifically in adults, as being very stereotypic. They look a certain way very, very consistently. They're usually in one part of the head on one side. And they have, pretty set, an individual might have a pretty set pattern to what they look like and how they feel and what kind of symptoms they get. But in pediatrics, it's not so clear cut all the time. They're described as more, rather than stereotypic, they're more protean. I may have mispronounced that word, but they may not be unilateral. They may be bilateral. The symptoms and the qualities can vary from time to time. And they also might present with more abdominal focused features, more digestive symptoms or pain in the stomach, in addition to, or maybe even more prominent than any sort of headache pain. And so we can see that there's these 3 categories of conditions that are more prominent in pediatrics, but and exactly how they present might be a little different, and they might be related to some of these changes that are occurring in their lives biologically, psychologically, and socially. And so considering where a child is at is really crucial in their ecological context and their development over time is really crucial for being able to assess and treat a child or teenager or young adult.
Yeah, absolutely. I think about I'm thinking about from a parent perspective, how they don't always know because kids don't always know how to communicate, right? I think I shared in maybe your talk about headaches and that my daughter had migraines and we had no idea she was having migraines. She was just throwing up a lot. So we thought it was maybe her medication, and it wasn't until her neurologist was like, oh no, these are migraines. Then we were like, oh my gosh, because I didn't know a child that young could get migraines. And she certainly didn't know how to describe it. She was 6.
Yes.
And so just we're all doing the best we can as parents, and we are going to miss things. And also we're all doing the best we can as clinicians. When we hear clients talk about, like, I have stomach issues a lot, we may immediately think of anxiety. We may, talk to the parents about what's like, is your child eating enough? Are they drinking water? Like some of the basic self-care things, but there may be something else going on that we just miss because it's not our wheelhouse, like it's your wheelhouse. So, yeah.
Well, we all have our lens and our way of looking at things, and we have to just recognize that's part of life. We can do our best to overcome that and educate ourselves to have a wider lens, but we're all going to view things, at least initially, through our lens of our expertise or our experience. So I think that's completely a normal experience. And I just want to help any parents or clinicians listening in to, take a deep breath. It's okay. You don't have to be hyper vigilant and focusing and searching for all these possibilities, because that also could be counterproductive. So it's about, educating ourselves, appreciating that these things do happen in childhood and pediatrics. I think that typically the bias culturally is to not appreciate these things are going on, or not to be aware, or not to consider this as one of the concerns that could be going on with a child. I think a lot of people consciously or unconsciously just don't think chronic pain, childhood, and or recurrent pain, or pain kind of being a concern. And so I think, just appreciating that this could be something that's going on for a child that you're working with, or could have been happening for an adult that you're working with since their childhood, that maybe didn't get properly assessed or diagnosed or treated, I think is a great place to start, at least.
And do we find, like, in the research, the things that a child struggles with in childhood, whether or not it's addressed, is it typically the same kind of complaints or symptoms in adulthood?
This field is really in its infancy. And so it's challenged because we don't have decades-long longitudinal
Right.
data to really go back to. So the best data that we have available really takes one of two lenses. One is, retrospective recall, asking adults with chronic conditions to ask what they may have experienced in their childhood. And that has its benefits and flaws, of course. And then the prospective of doing these shorter term longitudinal studies, tracking children or teens into at least their early adulthood, and trying to figure out what matches on. And so the data is still early and mixed, as you might expect. If you look at the retrospective recall, again, a few studies have started to look into this, maybe as part of their protocols, but maybe not the main focus. And they do find that about 1/3 of adults who are reporting chronic pain report that they did have some sort of chronic pain in their childhood. Whether it resolved for a period and then showed up again later is a question, I think, still TBD. But they do also track children or young adults with these conditions and track them into, a few years later. Some studies have shown recurrence or chronification of certain conditions. Some have shown that maybe the symptoms show up differently, or they're maybe more likely to have different things in the future. So one study tracked children and teens with abdominal concerns into somewhat later in life. And they did find that although there wasn't a super high degree of correlation of GI concerns or abdominal concerns in that period, they did have those children who did experience those in childhood did have a higher incidence of things like anxiety. So I think, it's still in its infancy. We're still kind of figuring out what maps onto what, but it is, I think, a reasonable assumption to think about maybe somebody has a vulnerability to an illness or pain that has these concomitant comorbid concerns often that are, I say comorbid, not exactly, because it's all intertwined. It's all one thing. It's not these two separate things that are just co-occurring in a vacuum. But maybe, a child might experience one kind of pain presentation or psychological presentation in childhood, and then that may show up a little bit differently in adulthood. But again, you throw in the opportunity for treatment into that mix. If we can treat them, or provide effective treatment, does that change the course? Does that change the trajectory of what we see later in life? And that is what I love to do about this field, is I really believe strongly, although again, the data is in its infancy, that by intervening and promoting healthy adaptive coping earlier in life, maybe symptoms show up, still things show up later in life. We can't control everything about our genetics, our environment, our biology, but can we at least change the trajectory of how somebody will experience those symptoms, how they might show up, and how they're they cope and manage.
Got it. So I'm wondering, is there a correlation at any point in the lifespan between what we think of as more of like the psychosocial side of things and the physical symptoms? Like I think about like anxiety and tummy troubles, right?
Mm-hmm.
I feel like that's in the zeitgeist. Like I'm seeing memes about this all the time now, right? Is there actually data correlating like people with these kinds of physical symptoms maybe experiencing these kind of emotional or social symptoms?
Like later in life?
Or at any point, like, 44-year-old with tummy troubles, maybe dealing with anxiety, 8-year-old with headaches, dealing with, I don't know what, depression, or making stuff up.
Yeah, no, I think those are great questions. There's a lot of research looking at kind of what goes with what, at least, cross-sectionally, right?
Mhm.
In a given person at a given time, and we do find a lot of comorbidity or correlation between chronic pain and health concerns and internalizing symptoms a lot of the time. So anxiety, depression seem to go hand in hand.
Mhm.
There's a lot of questions about chicken or egg, what came first. And I think for a lot of people that might vary the temporal chronology of what started and what was a result. For some people, they describe that one led to the other, or one kind of onsetted before the other. And at the same time, it could be that they're both manifestations of the same central holistic process that's going on in the brain and body, but just one showed up before the other. So it could be
Mhm.
one's causing the other. It could be they're all unified by a central mechanism or process that's going on. And that kind of goes back to, the artificial separation between the psychological symptoms and the physical symptoms. But some people do describe very clearly that, most their anxiety or most of their low mood is connected with their experiences of their chronic pain or illness. But there's also data that show us that, people who are anxious or depressed or have sleep problems or very stressed, that makes them vulnerable for experiencing pain after a stress or like surgery. So
Mhm.
I think it is very dynamic, and there's probably a lot of, the idea of like equifinality or multifinality, a lot of ways of getting to the same place that
Mhm.
somebody might show up in your clinic or in a research study with these seemingly separate but together processes going on.
Absolutely. Yeah. Okay. So we've talked a good bit about kids,
Mhm.
which includes adolescents.
Mhm.
Um, um, let's move into like some of what we see in adulthood.
Yes.
Maybe earlier up in adulthood, up until that random line of now you're elderly.
Right. Yeah, that's a large swath of life. And I think we
Huge.
typically think of it as kind of like a homeostatic stage, and maybe this stage of life is characterized by somewhat relative stability. I think when you at least compare it to early childhood and all the development and changes that are going on, and then what might be going on in somebody's older years, post-retirement or whatever. So I think it's marked by somewhat stability, but I think it's important to remember a lot could be going on, but maybe at sometimes it feels like everything's happening at the same time, or maybe it sometimes at least feels like, these things are happening in some sort of sequence, but things that can happen in adulthood that might affect presentation of pain or experience of pain once it's already happening are things like injuries, pregnancy, life changes, work changes, family and relationship changes. All of that is kind of constantly unfolding, and role changes in someone's life. And so all of that could certainly affect things. There was one interesting study that I was reading through, and it showed that kind of this what they described as middle adulthood. So kind of mid 40s to mid 60s before, again, that artificial cutoff of older adulthood. And they found that at this age range, there was a higher degree of association. They didn't find any major changes with actual pain sensitivity or pain intensity, the intensity or severity to which people experience pain. But they did find a higher association between the emotional response to the pain and the pain-related behaviors. So that could be anything from grimacing and guarding to changing your life related to your pain. And the authors hypothesized, they didn't measure this directly, but they said that it could be generational changes, because again, we're looking at one snapshot in life. We haven't replicated this across the centuries. But also they really focused on the idea that, the cognitive changes that might be occurring. And by cognitive, I don't mean things like memory and attention, but kind of our interpretation of pain. And so you might imagine that somebody who is entering this, what they described as middle adulthood, might have a more difficult time accepting their aches and pains as age-related and typical, whereas somebody who might be in their older years might be more accepting of their pain and might be attributing it. So it's this attribution or interpretation, attributing it to expected age-related changes. It's also important to recognize that depression is highest in this middle adult age group, and at least when it comes to primary care presentations. So I think it is interesting to think about, how we attribute the pain and how we expect it, and again, what is going on in someone's life that it might show up. And again, I think, I see this clinically. Again, I work more with children and teenagers, but I think it is interesting when what we attribute the pain or the signals in our body to really affects how we respond to it. So one of the things that I've worked on with children and teens in the past is when we start to experience chronic pain, wherever it shows up, in the body, we start to become a little bit hypervigilant to it, and we start to notice all the little signals and the twinges realistically, because we're looking for the next big thing that is going to really be miserable or set us back in some way. But we start to maybe overgeneralize. We start to overinterpret every signal that's happening. Similarly, we also might start pulling back from activity, and so then doing those things starts to hurt more. But when we start to recognize that, I'm doing this thing that's harder for me than usual, and maybe I can interpret that as more soreness versus pain, and I can learn to appreciate those differences based on what I'm doing in the expected signal or subtle differentiations in how it feels in my body, then, we can respond to different things differently and in a more adaptive way to what is actually going on. And so I think that is maybe a process that is also unfolding in a different way in middle and later adulthood.
Yeah. I'm thinking too about, as somebody in my 40s, middle and later adulthood, like the sandwich generation situation, right? There's a different kind of pressure for most of us at this age, where if we have children, we're taking care of them. If we have aging parents, we're either waiting for a shoe to drop or we're taking care of them. Yes. Like my interpretation, honestly, whenever I feel any sort of pain, is like, I don't have time for this. And so I can, yeah. And just thinking about how, like wanting to be dismissive, but sometimes it's loud. Sometimes it's my body being like, you didn't need to calm down, stay yourself down.
It's this constant tension between listening to our bodies and what it's trying to tell us versus maybe learning to pay attention to what that signal is actually telling us. And so I think for individuals who are moving into a chronic pain presentation, again, some of those signals are being overgeneralized, or some of those signals are starting to take over, right? So it's really that tension of kind of really, assessing where you're at, or as the clinician helping your client assess where they're at, where these signals are really coming from. But I think you're right, in the sandwich generation, there's so much in the air, and we're taking care of so many other people, especially, people who are prone to taking on a caregiver role, that it it kind of leaves somebody deprioritizing their own self-care. I see that in a lot of parents of children that I'm seeing, is that they are sacrificing their sleep, their self-care, their stress management to care for everybody else. But, the old saying of not pouring from an empty cup certainly applies here, I think, and easier said than done. I would never presume to tell somebody, oh, it's just a quick fix, you just need to sleep more, because that's hardly realistic for many teenagers with a lot of pressure that they have, and even more so maybe parents who are navigating work and caring for both parents and children of their own. But certainly just, at least you're right, like kind of a wake-up call to at least say, what are some baby steps we can take? And, if parents are bringing in children to see me, I really often try to think, okay, what can we take on as a family? What can we do to work on this together, then, rather than me kind of coming in and fixing your kid? Let's maybe work together and try to help everybody make these small but sustainable and impactful changes.
Yeah. Yeah. I like that. So what else are we seeing in adulthood that maybe we didn't see in childhood and adolescence, or is a continuation of what we saw in childhood and adolescence?
Sure. So, I think we talked about constant processes of growth and decline, but certainly that latter thing is something we are maybe paying attention to more as individuals age. Certainly our cognitive processes, some of it is sharpened, some of it is honed, our experience is honed, our memory for certain things might be sharper than, and our vocabulary and our ability to self-assess and self-reflect. That being said, there's a lot of changes that are also happening, like musculoskeletal changes, mobility changes. And then I think kind of like a cognitive set of kind of being set in our way of doing things kind of comes up more in adulthood. So things like, loss of muscle or an aging musculoskeletal system might lead to more prominence of more back pain, hip pain. So you'd asked earlier about, well, like, does something show up differently or the same as somebody grows older? And these are conditions that are typically more common in adult years, but certainly back pain can present in younger years, but maybe could or maybe not connected with different experiences that occurred earlier in life. We also start to accumulate diagnoses, something that children and teenagers start to experience too, but we start to have multiple musculoskeletal conditions that are maybe starting to interact with one another, or inflammatory processes. So I think that's an appreciation in adulthood. There's kind of multiple systems that might be going on, and that really requires just a broader lens, or multiple people kind of at least working together. And I think there are some advantages. We, growing older into our older years, we may have developed a lot of psychological reserve and capacity and resilience factors that have helped us get through life, and building on those strengths and those experiences, I think, is a really beautiful thing. But on the flip side, there are unique challenges to this population, and especially as we move into the older years, when people feel like their lives are kind of slipping away, like their routines are changing, family changes, loss of work or meaningful employment, possible financial strain. Those things can all certainly be affecting children and teenagers and younger adults, but certainly become more common themes as we kind of move through the lifespan.
I'm wondering about, like you'd mentioned earlier, in a primary care setting, it's that 40s to 60s where depression shows up more. I know I always hear about the oldest population as having more depression, particularly oldest men. Like, has that shifted over time and my data is just old, or is it more like this is how it shows up in primary care versus, in a psychiatrist's office or in, a surgery center or whatever?
Yeah, you're right. I think there's a lot of different data out there. So I've not myself performed a meta-analysis and can give you a accurate assessment of the state of the data. But I think it is important to recognize, first of all, how maybe different things present at different ages. And I think that's a helpful perspective as a therapists to have is that different things might be expressed differently, shown differently. Age-wise, culturally, certainly factors in. We haven't even addressed that yet.
Mhm.
But, but also, a lot of patients or clients who would benefit from seeing geriatric specialists do not have access to that. So they're seeing somebody who's supposed to be, it's a challenge to be a specialist or be well-versed in the entire lifespan. That's
Yeah.
what we're trying to accomplish today. But certainly, whether it's a primary care physician or a specialist physician or a therapist, it is really hard to know, all the unique biological, psychological, social challenges, and being adept at appreciating, assessing, and treating all of that is really challenging. And there are unfortunately not enough geriatric specialists sometimes. So I think that is one challenge is, people getting access to providers who really appreciate and understand their unique stage in life.
Mhm. Absolutely. So like that makes me think about like the role of psychology and better health interventions across the lifespan. Like you said, it's a rare person who would be able to address any age of person with the same level of expertise that somebody who specializes in a specific age group around the psychology of pain. You'd also mentioned that acceptance and commitment therapy is being kind of modified some for children at this point, and that it's used a good bit with adults.
Mhm.
Can we talk some more about like health interventions for like psychological health interventions that therapists can either just be aware of or employ themselves or refer out to a specialist who provides this?
Great question. So I think the cool thing about the field is that there is, pain treatment, pain research has really, to a large extent, relatively embraced the role of psychology and therapy as a primary form of intervention. Certainly, you'll definitely encounter people who don't view things that way, whether it's clients or other providers or researchers or policymakers. But I think with the International Association of the Study of Pain really defining pain with an inherent emotional, psychological component really promotes the role of psychology in this field. So I'll tell you, at least personally, when I went to pain conferences, like pain specific conferences, you would usually get a really even mix between, medical providers and psychological providers. And that was
Awesome.
and researchers. So it was really, really cool to see. And I think it's really great as a therapist to build great relationships and serve as a liaison and an advocate for the role of this kind of work across the lifespan. That being said, there's been a proliferation, a boom of studies into all these different various techniques that therapists can use to help individuals. One of the best well-studied treatments is CBT, or cognitive behavioral therapy, but there's been a lot of research into ACT. There's kind of all these offshoots of CBT, like ACT, or some people say ACT, or reprocessing therapy, or more trauma-informed interventions. There's all these different proliferations or different versions of therapy. EMDR has some research. And then kind of, more specific or focused interventions, motivational interviewing, solution-focused therapy, relaxation or mindfulness-based stress reduction. All of these have degrees of evidence and research to support them. So I think the cool thing about the field is that that's starting to grow in a way that is focusing on personalization. What meets the needs of the unique individual. And so going back to the axiom, focusing less on pain and pain in the individual. Oh, and I need to apply this treatment to just manage that pain, and focusing instead on the individual in pain and what might suit their needs and their capacity and their strengths the best. I do think strengths-based interventions, positive psychology is also a really exciting avenue to grow in, and can be applied in different ways across the lifespan. I think in the past it's been a little subservient to the more traditional focus on let's just get rid of the negative, but rather than focus on growth and well-being. But I think that is starting to be a little bit more of a focus across the lifespan. And I'm really excited about that particular intervention that can certainly be combined with, it doesn't have to be in an exclusion to other kinds of interventions or techniques. So I think there's common principles across these interventions of focusing on controllable aspects of health with behavior change, cognitive, emotional processing of symptoms, and promotion of functioning. All of these things kind of come into play with all of these interventions, maybe in slightly nuanced ways, or with slightly different areas of focus. So I think, if you're a therapist treating somebody with chronic pain, really focus on that individual. What do you feel like they need? And if it's something that fits within your capacity and your area of expertise, fantastic, you're a great fit. If not, but it's something within your zone of proximal development, is that something that you can learn and get more training on to be able to meet their needs? If something that they need exceeds your scope of practice, your area of focus, or it maybe you're trying to work on multiple things and pain-related topics are starting to distract from the other very important work that you're doing, those might be great opportunities to consult with or bring on an additional specialist or make a referral to another specialist to be able to be part of that person's team.
Wonderful. Can we talk some about just the biopsychosocial model of pain? We've mentioned it a few times and we've talked about it in another CE or two, but can we break that down for people?
Sure. So it's kind of artificial to break things down because the idea is that these components are all intertwined. There's great research and articles trying to summarize these concepts. So it's kind of difficult to just break it down and just, state it really fast. But in my best, and this will be my best attempt. So I think most people start with the biological. It's easier to say first. And I think that's where most of our minds go when we think about pain or other health conditions. Biology, I use the word loosely, and that term is loosely applied because it refers to a lot of different mechanisms of pain processing in the body and brain. It can go from really micro levels to appreciating the neurochemical changes that occur or that trigger pain or occur with pain or promote pain, all the way up to larger scale musculoskeletal systems or neurophysiological systems that are occurring in the body. So it goes from the really tiny molecular levels all the way up to larger interactions and processes in the body. So that's the biological. And then you layer on the cognitive or the psycho component. That has to do with different things like our interpretation of the signals. It has to do with our brain's ability to send those signals down to our body, our interpretation of other things going on like stress, memory formation, identity formation, all play into pain. And our expectations, our attentional focus are just some of the cognitive processes or psychological processes that are occurring with pain. Emotional processes, you can maybe lump in that category. And then the social context, you can imagine where, the relationships people have, the communication and interactions people have in their immediate or more distal environment certainly play a role in how we experience pain, how we communicate pain, how we manage pain, and how our pain continues to unfold over life. So all of these processes are going on for young children, for babies, all the way through life. And I think just keeping a wide lens on all of these things is important for assessment and appreciation and understanding of what's going on. And then being able to advocate and for the role of therapy and psychology in treating and helping manage. And so all of these processes are going on with any sort of presentation of pain. I think it is fair to say that with different presentations of pain, maybe parts of that triad are more emphasized or more prominent or more impactful, but they're all going on all the time. It's really an artificial dichotomy to say that's physical pain, that's psychological pain. You could imagine as a hypothetical, let's say my stress is causing pain. I don't like that phrase, but let's even imagine that had validity and that was true. It would still operate both on my emotional and psychological level. It's still happening there, but it's also definitely still happening on a biological level. It is still my body sending signals down to my body, communicating through nerves, activating different peptides, tensing different muscles, and that body giving those signals back up to my brain. Or even if it's just a headache, there's different, it's all occurring locally, but it's still both happening in both directions. And then my social relationships, imagine if I'm a child, my relationship with my parents, how my parents treat me, how they react to the pain, how my school reacts, or any relationships I have there. All of that is going to factor in, no matter where the process is starting. So certainly that might affect how we address it, but it does not diminish all of those different factors being at play and interacting with each other. And so I think the reason I like to bring this up is just to show the role and validity for psychology in any presentation of pain, whether it starts with an injury or starts somewhere else. Also the futility, and doesn't always make sense to search for when it started, because we're dealing with what's going on right now. And then also, invalidating any sort of pain experience because there seems to be an emotional component. I think that it's very damaging and very harmful. All pain is real. And that's, I think, one of the main reasons I like to go back to this model is all pain is real. And kind of, I think breaking things up or saying this is all psychological or this is all physical is both untrue on how it's actually operating and very potentially harmful.
I think about just the phrase like, oh, it's just anxiety, right? Like when you're talking about a physical, something that physically may be resulting from the anxiety, possibly we can't ever know, right? It's also tangled up, and feeds into one another. But I can't count the number of times I've heard people say it's just anxiety when somebody's talking about a stomach ache or a headache or something like that, like it does make it feel less valid when you frame it like that. It makes whoever's experiencing it feel, or even if they're the ones saying it, feel like it's more their fault somehow, versus this idea that like a physical malady that just comes onto your body or whatever, like it's not your fault, but anxiety is. Yeah, that's like a messy, sticky piece of this.
Yeah, very much so. I think the rosy view on that was at least we recognize the role of the mind and the body working, how they interact and how they, and that's great. That means that, that if your stomach is hurting because you're anxious, maybe there is a role for, addressing that and saying, okay, I appreciate that it is what it is. And maybe I am vulnerable and sensitive in that way, but maybe there are things I can do to manage and move forward with that. But you're right. It is disempowering. It is blaming. It is often, much more harmful than it is beneficial. But I would hope that the true intentions of trying to say that, whether somebody intends it or not, maybe there is some silver lining to that statement.
I guess so. I'm an eating disorder therapist, and our sessions, we do talk about food and body, but it's certainly not the bulk of what we talk about, right? So I'm assuming as a pain specialist, you do talk about the pain, but it's not necessarily the bulk of what you're talking about in session the whole time. Is that accurate?
Exactly. It's always that tension. I want to acknowledge and validate the pain. So we are checking in on it occasionally, but more so we're working on skills or ideas or topics and really trying to hold that dual focus on both managing the pain symptoms, but also functioning and well-being. So my goal, I try to help people have multiple goals that they're working on and realizing that they're all valid. And that we, having multiple ways of measuring success and multiple things to focus on is the best way of having a successful outcome in therapy versus having this one thing that you're so focused on reducing. I definitely think that's valid to want to do that, but there's probably multiple things that you're focusing on. And certainly there is a risk of being so hypervigilant and attentive to your signals that we're actually being counterproductive and noticing and experiencing them more.
Yeah, absolutely. I'm thinking of some clients I've had over the years where I didn't know what to do with the pain and would work on the feelings around the pain and the things that they believed contributed to the pain, in their either social or emotional environments.
Yes.
So I guess in those kinds of situations, they were clients where the pain wasn't the thing bringing them in. And so I continued to see them. But I'm wondering, I'm trying to think of where that line is, where I would have been this is somebody I definitely need to refer out, just anecdotally or as an example or a story. Can you think of anything that would help somebody frame their own client population to make sure they're not doing harm by continuing to see somebody they can't help?
That's absolutely valid. I want to reassure you, there's no hard line that you just have missed, that just no one has told you, and I'm about to tell you the secret. And up until now, it's been all wrong. There's no hard line. And I think that's both because everybody's an individual, our clients, but also us as providers. And so being able to meet people might be a little bit different, whether you label yourself as a generalist or a specialist in a different area versus a pain-related specialist. Even amongst pain-related specialists, there's different kinds of formats of treatment. So being in private practice, I might take on and work with certain individuals, or might consider more intensive rehabilitation interdisciplinary programs for people who need that. And so certainly I think we're all using a lens of, is this person the right fit for my practice? And so I think some things that might help you determine that, if somebody's presenting to you initially versus sharing or appreciating these experiences as they unfold in treatment. A couple of things that might be some ways of thinking about it, again, are just weighing how much is this symptom interfering with our treatment that we're already doing if we're in the middle of treatment. How much is this taking away from what we're able to discuss if we're working on different goals? Really, that's kind of what we came to work on. And is that okay? Is it okay to shift for a while? Or does it feel like it's distracting from something also equally urgent? Is this causing a high level of distress or debility? Those might be reasons to consider concurrent or a separate referral. Or if it's a concern that you're not sure has been accurately diagnosed. If somebody has not seen a medical provider, that might be a good reason to at least encourage that, just to make sure you know what you're dealing with, and educate yourself and help make sure somebody is getting the right level of care. Of course, if somebody is experiencing some lability or some risk behaviors related to their pain, those might be concerns to elevate those safety plans or protocols. If somebody is self-harming, suicidal, you need to be considering what are the appropriate venues to getting that person in a more stable place. And maybe that means the safety concerns. And then maybe secondly, that means bringing on a pain-related specialist. But I think sometimes we overinterpret that too. Not that we overinterpret the risk, but sometimes when somebody is presenting as, really depressed or suicidal related to their pain, there's often, those depressed cognitions or those depressed emotions are things that a therapist who's versed in treating depression can certainly help with, no matter what the actual situational factor that's triggering those processes. So I think I want to both empower anybody who's taking this course to really, believe that you have a lot of skills. If you use any of your skills that are probably helpful for any other conditions that you tend to work with, are probably to a degree really helpful for people with their pain concerns. But like any of us, there kind of comes to a unique point, whether it's something that's coming from the client or something that's, a limit on your capacity, or a dynamic interplay between the two that might tell you it's time to refer. So there's no hard and fast rule. If it helps, I sometimes like to think about whatever you're tending to work on, let's say it's eating disorders or anxiety, on some sort of continuum, and then the pain related concerns on a different, maybe orthogonal continuum. For those of you who are able to see, I am holding up kind of like an XY graph on my hands. That's my attempt anyway. And so you might think about where somebody's landing on those related intersecting concerns, and then using that to really help you consider whether somebody might benefit from different kinds of treatments. Of course, also asking them, what have they already done? What have they already done to address or learn more about these conditions? And considering where somebody might be a best fit. So that's a very long-winded answer. There's no
Wonderful.
simple little line.
Uh-huh. And then my next question is like a can of worms that we probably can't get into too deeply today, but I'm thinking about the interplay of like medical trauma and pain. And I'm curious how often pain specialists end up seeing that dynamic. It seems like most of the data around like pain psychology is mainly like top down, though it did sound like there's some like EMDR and some other things, but thinking about some of those bottom up treatments for trauma that can be really helpful. Like, how do you navigate? Do you need to work on the trauma before the pain? How do you conceptualize that? I'm sure it's individual for clients, but like, how do you think through that?
Great question. So you're right. There's both bottom up and top down processes that are occurring with pain, very parallel to trauma. So there's a lot of parallels mechanistically that we can think of there. And then certainly people with pain often report that they've experienced trauma, and it could be trauma from the different parts of their lives. There's certainly relationships with ACEs and pain later, but also medically related trauma could be related to experiences they have had getting assessed or treated for pain in the past. I don't know if I would qualify. I think, there's a healthy debate to be had about what qualifies as trauma, how we define it, what kind of scope and lens we use, and benefits of keeping more broad or narrow scope. But I think it is helpful to appreciate that a lot of people with pain, especially when it's chronic or recurrent, have experienced some level of stigma, whether it's in their families or their communities or amongst medical providers, about that pain, especially with certain subsets of diagnoses. So just appreciating that, if somebody's coming to talk to you about it, you're like potentially, but likely not their first person that they've talked to about this, or first experience that they've had trying to work on this. So just appreciating that lens, I think, just goes a long way. I think the communication that we do around, acknowledging that both processes of bottom up and top down might be occurring. But in terms of how a therapist can help navigate or what to prioritize, you're right, it is going to be individual. I think the cool work of being done to appreciate the dynamic interplay in day-to-day lives of different symptoms going on for people and different experiences is still being discussed and investigated through cool new tools of evaluation and assessment. So for instance, I have done some work using actigraphy and ecological momentary assessment to be able to better understand what's really affecting what, to eventually be able to help people. And there's other kinds of approaches that have been done to try to help clinicians know what to focus on first. Another way that, I think I am really excited to see is, really focusing on working with the clients to set their goals, and really appreciate, and using that as really a framework of what to prioritize. One of the common things that we sometimes see or one of the few things that I think have seen pop out in the literature as being a good target to focus on first or initially is sleep. So I think that's something that sometimes people report, oh, it's my pain interrupting my sleep, and that might be very valid. But we all probably can appreciate that there's a little bit of a bi-directional relationship there. And even if temporally or chronologically in somebody's history, the pain started before the sleep problems, we do have some data that shows that addressing the sleep itself can be beneficial at starting a ripple effect and then making the other interventions that we might be using a little bit more effective. So I think there is something there to anchor onto. That being said, I think you're right. Like there's, whether we start in some sort of desensitization process, whether it's sensory desensitization or desensitization to stress signals, or, reprocessing pain signals versus doing more, how do we, challenge our thoughts related to stress or our functioning, doing that first, I think, to my knowledge, still should be based on clinical judgment. Personally, I do find, especially working with younger kids, it's easier to start with some of the behavioral techniques first, work up some rapport and some appreciation for what somebody might be going through a little bit more before diving into some of the more cognitive processes. That's my clinical inclination.
What else about pain across the lifespan have we not talked about that you want people to know?
I think, we talked about the lifespan, and I think I've alluded to this, but I think I just wanted to make a plug for pediatric focused work out there for any of you who might be working with children or teens or young adults. This is an incredibly potentially powerful population to be working with. To be able to appreciate that they may be experiencing pain goes a long way of just being able to recognize it and get kids more into treatment. And then potentially that treatment could, I think there's a really powerful argument to be made of changing the trajectory of people's lives. So we know that chronic pain is in adulthood, nationally, globally, one of the most devastating financially, economically, morbidity wise, amongst adult populations, and certainly amongst kids can have that impact on an individual family. But we can maybe change the trajectory of individuals' lives, and I think generationally, by recognizing and intervening early. Currently, it takes many individuals who experience chronic pain, it takes them, often years to get in to see a specialist or somebody who is able to treat it from an interdisciplinary perspective. So any work that you're able to do at helping recognize, assess, and treat or refer to treatment, I think goes a long way, no matter what age that you're working with. And I think the exciting thing is we do have tools that help. No one tool is going to be a perfect magic bullet, at least as of right now. I know that everybody's desperately working on the new and latest and greatest things. And I think it's exciting to see the investment in this work. But there's no one magic bullet. And but the good news is that there's a lot of tools at our disposal to help. And I think we talked a little bit about the biopsychosocial model and recognizing that therapy and psychology is a great and effective and often should be really considered as a first line approach. So I think there's a lot of like, oh, well, if these other things didn't work, then we start to bring in psychology. But I really encourage people not to think of us as a last resort, but also recognizing that, we may not be the only tool for somebody to use. So I think that's also a level of stigma where providers or medical providers just send somebody to us because it's all anxiety, and not recognizing that we really should be continuing to work together. So the more work that you can do if you're working with this population to have great medical partners, or working with the medical provider somebody's already working with, considering other complementary treatments, like physical therapy or other complementary and alternative treatments. I wouldn't lump physical therapy in that, but thinking about building your team, I think goes along no matter what age group you're working with.
Wonderful. Emily, thank you so much for talking with us today. I feel like people can walk away with much better knowledge around not only pain psychology, but just like how it shows up differently and the same throughout the lifespan, so that they can be more aware with their current clients and clients that come in the future. So thank you very much.
Thank you for having me.
I hope that broadened your clinical horizons. Head over to notboringces.com to get your CE credit. Want to have a not boring conversation with me about your clinical area of expertise? You can apply there too. If you like this conversation, leave us a 5-star review, tell a friend, and be sure to subscribe for future conversations.